all yours, Rich.
Thank you. Thank you, Julio, for inviting us. And like Kevin, who tried to race through his slides, after having spent 12 years at NIDA, I think I'll just speed through mine. The drug users got it. Speed through them, right, okay. Probably didn't work for everybody, that's just fine. I want to shift our perspective for this presentation. We're going to shift to a different region of the world, one that we haven't really spent much time today talking about, but is of course included in conversations globally, and we'll be looking at Eastern Europe, Central Asia, Southeast Asia. Secondly, I want to shift our perspective from generalized and heterosexually spread HIV epidemics to concentrated epidemics, and though I will be focusing primarily on persons who inject drugs, formerly known as IDUs, by the way. I'll refer to them as IDUs, but they are now in the language called persons who inject drugs. But I want to acknowledge that I'll focus on persons who inject drugs, but in most of these countries there are overlapping epidemics with men who are having sex with men, maybe more emerging than it is high prevalence at this point, or very expansive, as well as sex workers. And the third perspective that I want to shift to, and I think is very important as we have this conversation about seek, test, and treat and retain as HIV prevention or as treatment, and particularly for this population, is to begin to think about the population for whom we want to seek our services, who is being sought out and identified, who might engage in treatment, and who might be retained in treatment. In many of these countries, it would be a great concern from the perspective of injection drug users to be identified, to be sought out, to seek out services. The consequences of that I'll mention in terms of some of the persistent barriers that limit this coverage and the scaling up of services for these populations. The punchline from this presentation will be how very, very low the coverage rates are in each of these categories, from testing through medication-assisted treatment or methadone and buprenorphine, which, as everybody knows here, there is both strong evidence that it prevents HIV transmission as well as it enhances adherence to ART. There are about 16 million injection drug users globally. We'll concentrate in those regions I mentioned. Together, there's more than 50% of the entire global population in the regions that I referred to. And in another fact, though, I just want to refer to, in terms of China, Russia, and the United States, more than 40% of all the injection drug users reside in those three countries. You see the colors in the maps, and I want to thank Brad Mathers and the UN HIV reference group on IDUs supported by the UN family. This is the data he shares with everybody. But you see the gradation in terms of prevalence of HIV by regions, and you see Eastern Europe with the highest prevalence. It's estimated from the data that there are about 3 million injection drug users who are currently living with HIV. Again, the pattern is similar as to the number of drug users by region, and you can see again in terms of Eastern Europe, the Russian Federation, Central Asia. This is a concentration of injection drug users that are HIV positive, and more than 50% of all the positives live in this particular region. This is my last slide with the regions named, so you'll have to use your geographic background to make sure you follow the results in terms of the regions. Let me start with the seek variable or the testing variable. And there are all kinds of limitations one would want to discuss, but we don't have sufficient time, with the data that comes from the Universal Access Database, from UNGASS, and as well as the epidemiological databases in terms of estimating the sizes of the populations, which, as you know, will very much be a factor affecting coverage rates. But however limited we are methodologically, some of the rates that you'll be reporting, even if there are errors, are going to be so small that the concept that you walk away with is that coverage rates are very, very low. and to expand services to think in terms of universal access to testing and or treating. You'll see the challenges ahead are enormous. This is from the UNGASS database of those who reported in the last year seeking out HIV testing, that is injection drug users, and also knowing their results. The numbers that are HIV positive that have sought out testing, we're unsure of, but we're very clear that of the 75% or so, let's say in Russia, in Eastern Europe, that didn't seek services, there's an enormous number of them that are HIV positive. I've added some information to these slides. I've used the rates because 25 to 50% is a substantial category. I want you to see it's closer to the end of 25% in the Russian Federation, 30% in Asia, and in Vietnam, 18%. I'm sorry, 37% is China, 18% in Vietnam. Larger numbers in the other country in terms of Ukraine. Now, we clearly have evidence from more than 25 years about the effectiveness of needle and syringe programs if they're implemented in terms of being high volume, being high quality, that they reduce risk behaviors, and if they're made available in a number of different venues and reaching large numbers of people. We already have a very cost-effective and intervention to limit the spread of HIV disease. This slide shows you just one indicator, and that is the numbers of injection drug users in these countries who have access to services, and access to services really means one time in the past 12 months. You see the distribution, and it varies. There are some substantial numbers there for Vietnam, which has a very comprehensive HIV prevention program, including a syringe exchange program. But you see in the countries with the largest numbers of injection drug users and the highest prevalence, and we're talking about Russia, and we're talking about China, where you see that the numbers that are able to access syringe exchange programs are very low. This does not include pharmacy-based programs, but it will not make a substantial difference in these particular countries. There, in Ukraine, the numbers are higher, they're at 39%. This is another indicator, but maybe equally and as a complement important, and it is how many syringes per year does an IDU receive, with understanding clearly that the more syringes one has access to, the less likely one is to reuse another person's syringe, which means it's less likely that there will be events where there'll be a transmission, exposure, and HIV positive outcome. And you see that there's the data in the regions that we're concentrating on. Not all countries report, but this is the distribution you're seeing. And medium coverage is up to 200, and high coverage is what one would like, would be in excess of 200. And few countries really are able to provide that kind of coverage per year per IDU. It is low, and it is low in the United States as well, I would mention. So this is the variable in terms of substitution treatment or medication-assisted treatment, as it's referred to in the United States, and referring to methadone and buprenorphine particularly. And this is, again, remembering there are real limits with a lot of this data, and there are ways to refine it, to improve it, and conditions I should mention, but we don't have enough time. But it would both distract and really wouldn't alter the conclusion one reaches from looking at this slide. And probably most prominent on this slide is the Russian Federation. That is, by law, they do not permit substitution treatment. That's given what we're talking about in terms of prevalence, numbers. This is an issue, and talking about this population of injection drug users, talking about universal access, seek, test, and treat, in terms of zero new infections and whatever else we might want to be referring to. These countries of China and Russia are very critical globally, not only in terms of countries and IDU populations. But this shows you what the current number of people in substitution treatment are in terms of per 100 IDUs. Would have to be saying tomorrow we will have an opportunity to hear from Wu Zhenyo and Sergei Dvorak, speaking from country perspectives, providing updated data and perhaps improving this presentation, challenging some of these numbers, and this will take us in another direction in terms of progress. But this is so far, needleless syringe exchange programs are limited in terms of access. Syringes per person are limited. Substitution therapy, which is very critical to adherence, to improving adherence for ART, is really very low. And this is the data in ART per 100 IDUs. Data is really sparse. This data is really problematic. It is really incomplete. But Degenhardt and her colleagues, using the UN reference group and the new 2011 paper that just came out from Mathers with UN support, is really reporting these data. And what you see is the number of IDUs per 100 HIV infected that are currently accessing ART, and the numbers are extremely low. If we look across a number of countries where PEPFAR is working, and I'll show the slide next, we will find that in these countries, fewer than 7 per 100 HIV-infected injection drug users are currently receiving ART. This is why I'll go to another slide in terms of barriers that will help us understand it. So when the modeling is being done and the coverage rates are being calculated and simulated, and those are generally fairly high, to what extent are those coverage rates either going to be based on real-world experience, given the limitations of data, and more importantly, for those of us in program who do technical assistance, and that's lots of people here in countries, to help improve program while we wait and hope that research evolves, matures, and we can translate that information into best practices. These are the kinds of things that are accounting for why we think it's going to be a real challenge in terms of scaling up, and where implementation science will be responsive to the challenge and help us develop some and test techniques to overcome some of these issues. In most of these countries that we are talking about, where we have low ART coverage, where we have limited MAT coverage, most of those countries, for IDUs trying to access ART services, they are excluded in general because they are active drug users. It is a disqualifying criterion, which means that when you look at some of the numbers in some of these countries of who's on ART, it is not proportionate to the burden that's driving the epidemics in these countries, but it is more responsive to some people who can access ART. And typically it is former drug users can do that. Oftentimes, and there are, in terms of other barriers, it is expected that you be drug-free. Well, you're not drug-free unless you can access some services and limit it, and everybody here knows that. But, and I'm out of time, so I'm going to really speed through. But I wanted to know that in terms of eligibility, without being able to access ART because you're an active drug user, without being able to access MAT so that you can move yourself into accessing services, this seek, test, and treat becomes an enormous challenge for everybody dealing with in this region. Doesn't mean there aren't going to be practical solutions, nor does it mean that implementation science may not hold some opportunities for us to explore different kinds of strategies to move forward. I would say that two other barriers I want to mention is that I asked the question, and I was very serious about it, why would you, from the perspective of a drug user, want to be sought out and or seek services in a number of these countries? It is not Baltimore. It is not Vancouver. And even there, drug users have some issues. But if you have to register with the government, and you have to use government facilities for testing and counseling, and if by registering you have to be identified so that you can begin to access services, your name just becomes part of registration that is shared across ministries and is shared in large part with the police. All right, I'm going to skip through these other barriers. The slide set's there. I will end with two slides. Hopefully I didn't sound like Dr. Doom, but I do really want to say that in terms of PEPFAR, the other multilaterals, the bilateral donors, the community, the WHO and UNAIDS and UNODC and Gates and everybody are working in these regions, and they are making investments, not enough certainly relative to burden, and not enough in terms of PEPFAR relative to the burden it represents in the population. But we have released a guidance last year at the meeting in Vienna. That guidance was to offer countries the best evidence we had to give them good technical advice to move forward. Pleased to say, for the first time, the United States government was willing to support through commodities the procurement of syringes and needles, and numbers of countries since the release of that have done that. And in closing, let me just mention that NIDA, with its resources, has really been very generous and has supported its own implementation science RFA, working very closely with PEPFAR to address some of these issues, hoping to move forward with asking the kinds of questions that have been asked all day. And the single biggest thing for us, and for me particularly, is to understand that testing different strategies that end up helping us reducing those persistent barriers will likely lead to the kind of uptake and the cascade of services that will be essential so that years out we will reach some of these goals in terms of reducing HIV incidence. So with that, thank you. And yeah, thank you. That's all.